Can you guys hear me? Okay. Okay, he's tall.
What? It was just a shame.
I know, but you're trying to make it do it again.
No.
It's too long. Okay, we'll go ahead and start, and then whoever comes in later, we can catch them up. All right, so I'm gonna kind of like bounce back and forth between the book and the study guide, and then once we get to the end of the chapter, I'll cut it off and then start a different live for the other. That way, it's not just like running forever. All right, so the first three things that I saw where nutrients undergo three forms of processes in the body, and that's digestion, absorption, and metabolism. And these were on a chart, table 16.2. I think she's definitely going to want to know those. I want to say, yeah, they're bolded words, and that's you bounce off of those throughout the chapter. So basically, the organs are going to use digestion and absorption for breakdown and taking out what's needed. And then the body cells are going to use metabolism. And then we know the alimentary canal can also be called the GI tract, and this is a continuous muscular tube from mouth to anus. And you are such a child. My husband is laughing. He's ridiculous. Okay, anyways, the alimentary canal is about 20 feet long in adults, and the main organs make up the alimentary canal. So if you're looking along on the study guide, the main organs are the mouth, pharynx, esophagus, stomach, small intestine, large intestine, and then those are broken down into smaller. And we'll get to that in just a minute. But basically, the main organs are from top to everything. Everything that you eat should pass through these. The accessory organs are teeth, tongue, salivary glands, tonsils, liver, gallbladder, pancreas, and appendix. And these do not carry food through them, but they do aid in digestion. So, ingestion is a process of taking food into the mouth, starting its journey through the digestive tract. Digestion is a group of processes that break down complex nutrients into smaller ones and facilitate absorption. So, mechanical digestion physically breaks larger chunks into smaller bits, and then chemical is going to break like the molecules apart. Motility is movement by the muscular components of the digestive tube, including processes of mechanical digestion. And two examples of that is peristalsis and segmentation, which we will get into in just a second. Secretion is the release of digestive juices containing enzymes, acids, bases, mucus, bile, and other products that facilitate digestion. Some digestive organs also secrete endocrine hormones and regulate digestion or metabolism of nutrients. Can you open the window?
Maybe I don't have to take two.
Okay, open the window. Absorption is the movement of digested nutrients through the GI mucosa and into the internal environment. And then we have elimination, which is just excretion, going to the bathroom, and then regulation. It kind of confused me as to why it was like at the bottom of it, but it's basically regulation is the coordination of digestive activity, motility, secretion, other digestive processes. This is when people say like you're regular, like you go to the bathroom regularly, everything's working properly the way it's supposed to be. That's what I think of when I think of regulation. All right, so if you're looking at the study guide, I'm sorry, I'm gonna have to take this apart. It has like 50,000 sheets. If you're looking at the study guide, this is the page that I'm on now. if you were able to print it. Basically, I broke it down in the alimentary canal into different parts. So we start at the mouth, and this is where mechanical digestion and chemical digestion are going to begin with bolus. Bolus is saliva and a ball of food, like just spit and food put together. So a ball of bolus. Mouth goes to the pharynx, down to the esophagus, and then you have your lower esophageal sphincter, which is also called a cardiac sphincter, your stomach, and then your pyloric sphincter, and those three go together. So we have the beginning of the stomach, and that's the end of the esophagus. Your food is churned and broken down into chyme in the stomach, and then the pyloric sphincter is going to keep it in there long enough for it to digest. So I also put on here the stomach saves vitamin B for later absorption. This is the intrinsic factor. I kind of tried to like tie in what happens where. That way you could just kind of get an idea. Because I wish it just gave you like a step by step instead of a bunch of writing, because then you have to go through and like decode it, and it's just too much. So now after the pyloric sphincter, that's going to open up into the duodenal bulb. That's going to go to the duodenum, jejunum, and the ileum. This is your small intestine. So this is nearly where all digestion occurs and most absorption. So most food is specifically digested in the duodenum, and the pancreas starts performing its functions around the jejunum. In the duodenal bulb and duodenum, this is about the same time the liver and gallbladder are performing their functions. And then water soluble and fat soluble vitamins come into play there as well. So then after your ileum, you have your ileocecal valve, and this is going to connect the small intestine to the large intestine. And it's kind of jumping back and forth, but I just wanted to get that kind of basis down first. Okay, so page 375 is where you can see the ileum connecting to the cecum, and this is the ileocecal valve. So basically just putting two words together, and that's going to tell you where the connection is. Pretty simple. The cecum is basically just like a little pocket at the end of the large intestines, and this is also where the variform appendix comes down. All right, ascending colon is where I put vitamin K on there because that's where it's going to start playing a factor in, and vitamin K is used for platelets clotting. So then we're going down to the ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, and rectum, anal sphincter. There's two anal sphincters, and then anus. So the large intestine is where lesser absorption occurs. I'm not going to say it doesn't absorb anything, but it doesn't have the plicae or microvilli or villi in it to absorb things. It's more of just like the tunnel for everything to go out. But most of your like vitamins and things like that are going to be pulled out here. It also deals in bacteria, good and bad, flora. And then I wanted to talk about the plicae in the small intestine. So I kind of tried to break this down a little bit better, but the plicae is like the bigger part that's lining your intestine, just a bunch of that. And then on down, smaller from that, are the villi, and then microvilli are even tinier. And they kind of remind me of plankton from SpongeBob. That's how I think about it. His little antennas would be like the microvilli, he's villi. All right, so then I'm going to go ahead and move over to walls of the digestive tract, and this is back. We're backing up on page 263. Try to break this down a little bit because it's just very wordy, but okay, so the wall's made up of 4 layers of tissue, and each one has a different role, and then they don't really run together, so that's kind of good. It should be easy to separate, but basically the hollow space where that food actually passes through is the lumen. I've been having a hard time remembering that word. I don't know why, but that's not a part of the wall. It's just the opening. So like you have a straw, the lumen would be the middle part of the straw. So mucosa is the innermost membrane, and this shouldn't be hard to memorize because mucous membranes are lined with mucosa. We want that kind of slippery, nasty junk in there because that's what's going to help food go down without like cutting us wide open. So the entire alimentary canal is filled with mucosa. Submucosa is the next step out, and this contains blood vessels and nerves. So you got to have blood vessels going to that. If you have some kind of a cutoff in the submucosa, you're not going to be able to digest food, and your intestines will actually die off, and that's when people will have to go and have part of their bowel resected. Give me just a second. Okay. So then the next one is muscularis, and it doesn't really give us a really good picture, but on 363 is where we're at now. Basically, muscularis is going to have all of your muscles in it. It shouldn't be hard to memorize because it has the word in it, but this is going to aid in moving food along. This deals in peristalsis and segmentation. This is movement, specifically movement through muscles. Serosa is going to be the outermost layer, and this is what makes the visceral and parietal layers. Let's see. All right, composed of serous membrane adheration to walls and organs. So the double folds of serosa extend between visceral and parietal layers and anchor the organs of the digestive tract to the posterior abdominal wall of the abdominal cavity. This large double fold of peritoneal tissue is called mesentery, and it keeps the abdominal organs in their places. So if you've ever watched a autopsy, those are pretty interesting. It's just like a weird sheet of like skin kind of stuff, and that's just what's keeping it connected to your body, so it's not just floating around in there wherever it wants to go. So you don't have a stomach in your neck. I suggest going and watching an autopsy on YouTube. They're pretty cool, and it helps me to be able to see it better. All right. Peristalsis is the rhythmic wave-like contraction of the gut wall caused by alternating a wave-like contraction along the circular muscle layer in the muscularis. Peristalsis squeezes and pushes ingested materials forward through the digestive tube's internal pathway. So peristalsis is more of like is just moving down. I kind of think of it as like using gravity. I kind of tried to tie this in before when we talked about different types of tissue, but basically, if you're in a fight or flight response, your peristalsis is going to be really slow, because when you're trying to get away from something, you're not really worried about pooping. You're not worried about digesting food. So your peristalsis is going to be just a normal flow of food heading down. It's getting ready to get out. Segmentation is different. This is the back and forth or swishing type of intestinal motility that breaks down food from larger to smaller bits for digestion. So they work together, but segmentation is going to use contraction and digestive juices, and peristalsis is going to use contractions and gravity. So peristalsis is just the moving down. Segmentation is going to be more of squashing it up. Let's see. All right, moving to the mouth. Jumping all over. All right, so we're on 365. So the mouth is a hollow chamber with a roof. It's lined with a mucous membrane. Like we said, your whole entire alimentary canal is lined with mucous membrane. That way we're not scratching stuff up. The hard palate is a bony structure in the front portion of the mouth formed by parts of the palatine and maxillary bones. And the soft palate, soft structure in the back of the mouth that's mostly muscle. If you were ever inquire in school, they would tell you to put your tongue on different parts of the roof of your mouth and to give different sounds when you're singing. We use those a lot, but basically the soft palate, you can feel it in the back of your mouth at the roof of your mouth, and then you can tell where the hard palate is. Hard palate is usually what you scrape up when you eat like onion rings or some really hard chips or something. All right, then I put uvula, the dangly thing in the back of your throat. Cardi B will help you remember that. It's the dangly thing in the back of your throat, and I really honestly didn't know it had a purpose until I started reading this chapter, but uvula and soft palate prevent liquids from entering the back of your nasal cavities above the mouth and assist in speech and swallowing. So I've never seen anybody that didn't have a uvula, but I wonder what that would sound like, and kind of want to like look it up now. But basically it protects liquid from going up the back of your throat because you don't want that. Frenulum attaches the tongue to the floor of the mouth. Remember that some babies have this. It makes it difficult for them to breastfeed and speak properly. So I think like frenulum floor, it's on the floor of your mouth. A lot of kids have to have these clipped. Then we're moving down to teeth. You have incisors, canines, premolars, and molars. So incisors are going to be at the front. These are going to be your plain Jane at the front. These are used to bite things off. That's the first thing that you're usually using when you bite into something. And that's the part that begins mastication, which is chewing. And then you have canines or cuspids, and these are longer and pointed, used to pierce or tear food into smaller pieces, and these are going to be the sharper ones. Then we have molars. Bicuspids are double pointed to saw through the root fibrous food. I kind of drew pictures of these. I don't know, it's probably ridiculous, but some of them look like they have two. This is normally what you see like on a dentist sign or something. They kind of shape like this. And then you have the ones in the back that are your molars, and those have the 3 points. And these are all for breaking down and grinding. The back of your teeth are used to those. So chewing begins mechanical breakdown. It's chewed into a bolus. Remember we said bolus, ball of food and spit. You start cutting teeth around 6 months, and then you start losing teeth around 6 years, which I did not know. And my 5-year-old's about to be 6, so that explains why her teeth have been bothering her. So then we're going to roll over to 366. The 3 main parts of the tooth are the crown, the root, and the neck. And I kind of think of it like candy corn, if you can see this. So the crown's going to be the top, the middle part is the neck, and the bottom part is the root. The top part, the crown, has enamel for protection, and this is where they tell us to get like a toothpaste with like fluoride in it to help keep the enamel strong on your teeth. They tell us not to drink a lot of coffee, drink a lot of wine, eat a lot of like acidic stuff, because it destroys the enamel in your teeth and you can't get that back. Cementum is for protection on the bottom half. So, sorry, I don't know why I'm losing my voice. Enamel is made to withstand the grinding that occurs during chewing of hard and brittle foods. The root and the neck of each tooth are covered by the cementum. The center of the tooth contains a pulp cavity made of connective tissue, which is like the most of the tissue in the body, blood, lymphatic vessels, and sensory nerves. The neck of the tooth is the narrow part that joins the crown to the root, and it's surrounded by the gingiva or gum. Inflammation of the gums is gingivitis. Untreated gingivitis leads to periodontitis, and periodontitis is the more serious infection of gums that's usually caused by gingivitis. So if you're not taking care of it, one thing's going to lead to another, and that's, I believe, the leading cause of heart disease. Oh, disease of enamel, but it's bad for your heart. Dental caries or tooth decay is a disease of the enamel, dentin, and cementum of the teeth that result in permanent defect called a cavity. So dental caries, tooth decay, cavity. Now I'm going to move over to salivary glands. There's 3 pairs of salivary glands, and there's one specific one she did want us to know. If she doesn't cover any more, she's going to cover the parotid. So parotid, submandibulars, and sublinguals are the 3 pairs of salivary glands. They secrete about 1 liter of watery saliva produced each day in an adult. So that's like 1 liter of Mountain Dew that your body's producing in saliva. These are considered excreting glands because they convey their secretions by way of ducts, and they aid in digestion. So that is going to be amylase that's being produced in your saliva. Parotid glands, this is where the mumps would be, and she kind of explained it to be like this area right here. Mumps can cause sterility in small boys if not treated. So the largest inferior and anterior to each ear at the angle of the jaw secrete a solution containing sodium bicarbonate that helps neutralize bacterial acids. Submandibular glands are on either side of the lingual frenulum, so that's like down here, and then sublingual glands open to the floor of the mouth. Saliva contains mucus and digestive enzyme called amylase. This breaks down complex carbs. Water and mucus moisten and lubricate the chewed food, allowing it to pass with less friction through the esophagus into the stomach. So here we're going to read a little bit later, but we really should be chewing our food a lot longer because our body doesn't have enough time to break down things where they should be broken down. The amylase in our saliva should be breaking down carbohydrates before they get sent out and a couple other things, but we usually don't take the time to chew our food the way we're supposed to. So then I kind of try to break down functions and structure of the next couple things in like boxes, so it wasn't so stressful just seeing a bunch of words. But the structure of the pharynx is a tube-like structure of muscle lined with mucous membrane. Again, they're all lined with mucous membrane behind the nasal cavities and mouth, and it functions in respiratory and digestion. So air passes through on its way to the lungs, and food passes through on its way to the stomach. It's subdivided into nasopharynx, oropharynx, and laryngopharynx. And this is what we learned in the last test we had. And tonsils protect us from infection. It's usually like our first step because that's where we're breathing. So the function Oropharynx is mostly directly involved in digestive processes because it involves swallowing. Swallowing is also called deglutition. What? I thought you said something. Deglutition. Mastication involves voluntary movements to make bolus of food and saliva in the mouth, and then it's involuntarily moved through the oropharynx into the esophagus and into the stomach. So it's just a one-way ticket down. And this is on page 368 in a picture. Swallowing requires coordination of pharyngeal muscles and other muscles in the head and the neck. So if there's something, an issue in here, you're not going to be able to swallow, and that would be where you have to be fed a different way. Regulation of voluntary swallowing movements is dependent on nervous impulses originating in the motor cortex of the cerebrum. So if there's an issue there, you're going to have an issue somewhere else. Involuntary movements are regulated by impulses originating in the deglutition center located in the medulla and pons. And she does like medulla, so I would probably know that. Esophagus is a muscular mucus-lined tube that connects pharynx to the stomach. It's about 10 inches long and serves as a passageway for a bolus of food and saliva. So it's just the train track down. Production of mucus lubricates the tube for ease of pass, and each end has a sphincter. So the sphincters are valve-like rings that keep the tissue, rings of muscle tissue that surround tubular structures of body openings. In the GI tract, sphincters are typically used to keep everything moving down and not moving back up, much like the valves of your heart. You don't want something coming back. This is where you start running into issues, and those are in our clinical applications. So the upper esophageal sphincter helps prevent air from entering the tube during respiration. And I'm trying to see if I can find a picture. And I don't see one on here, but that's okay. Lower esophageal sphincter or cardiac sphincter prevents backflow of acidic stomach contents. You definitely want those. You don't want heartburn all the time. So the stomach is next. This is on page 369 if you're following along. And if you guys have any questions or like comments or anything, you can just comment on here and then we can go back to that, or I can stop and go over it. So the stomach lies in the upper part of the abdominal cavity just under the diaphragm, and it's a large pouch that holds ingested materials after it's been chewed, swallowed, and passed through the esophagus. So it's pretty much just like a wrinkly bag, and it's going to pull out what it needs, and then it's going to send out what it doesn't. So there's 3 divisions when you first enter the stomach. You're going to be at the fundus, and then you have the body, and then you have the pylorus, which should be easy for you to remember. Pylorus and pyloric sphincter, those two are going to be together. But the fundus is enlarged, curving base towards the top. The body is the central part of the stomach. Pylorus is the narrow lower apex section that joins the stomach to the small intestine. And then you have a lesser curvature and a greater curvature. I don't feel like she's going to ask as much about that, but it is good to know, I guess. And it can expand. A lot of the times we eat too much and it expands too much. And then that kind of gets like makes you feel sick. And then a lot of times once you've stretched your stomach to a certain position, you feel like you're probably going to starve to death because you're having to fill that up every time. When really we should be eating a lot of smaller portions throughout the day, more of those rather than a bunch of like a few big meals. So there's 3 layers of smooth muscle in the wall. There's longitudinal muscle layer, circular muscle layer, oblique muscle layer. And these are, if you're looking on page 369, they're just lined differently. So kind of like you would weave a basket, or kind of like the heart muscles, and they're all kind of done together real funky. It's because you want things to be able to move in different ways. You want them to be able to move in different ways so that you're digesting everything that needs to be digested. You're moving everything that needs to be moved, and breaking stuff down. So this is where food is broken down into chyme. So it goes from bolus to chyme, B before C. Chyme is tiny food particles mixed with gastric juices, and this is a semi-solid mixture. Your stomach is lined with mucous membrane, and it contains gastric glands which secrete gastric juices into the stomach. These are very acidic. This is also why they tell us, we're doing tube feedings, that we need to make sure that we're wearing covering, protect your eyes, protect your mouth, because if something comes up out of that, that is nasty. Cells secrete intrinsic factor that protects B12 and saves it for later absorption in the distal small intestine. So when the stomach is empty, its mucus lining folds into rugae, and this just decreases and increases surface area. So you can see that on 369. It's just a bunch of wrinkles that are there basically to stretch. It's like, I would call them like permanent stretch marks inside of your stomach. And this is just to give more space to break things down. So the function is, after a bolus of chewed food and saliva have entered the stomach, the digestive process continues. Sometimes the opening of the diaphragm permits the esophagus into the abdomen is enlarged. This will cause a hiatal hernia. This is just moving something up. Hiatal hernia will result in GERD, which is gastroesophageal reflux disease. It's like severe heartburn, I would say. But basically, it's just a backup. Everything's pushing back up. Everything's coming back up. A contraction of stomach's muscular wall mixes swallowed materials thoroughly with gastric juices and breaks them down into chyme, and this liquefies. Every time I think about the stomach digestion stuff, I think of the Magic School Bus, because they had an episode where they went into someone's stomach, and it was pretty cool. But you see how like everything's bubbling around in there. Partial digestion of protein occurs after chyme is held in the stomach for a while at the pyloric sphincter muscle, and this closes to separate the stomach from the small intestine. So it's kind of like its own timekeeper. It wants to make sure that you have enough time in the stomach to digest what you need to digest there before it moves on to the next place. So loss of intrinsic factor in the stomach lining would cause pernicious anemia. I have a feeling she's going to bring that back up again because there's no B12 being saved. So treatment for pernicious anemia is B12. A clinical application I put in the study guide from page 370 is heartburn or acid indigestion are used to describe GERD, and this is the backward flow of stomach acid up into the esophagus that causes these symptoms that include burning and pressure behind the breastbone. So a lot of times, I think they actually changed the name. I mean, we used to just call it heartburn, but they changed the name because people that had heart problems were getting offended that we called this heartburn. It had nothing to do with your heart, but it was because it's behind your breastbone and it feels like it's your heart. It feels like it's really your chest hurting, but it's just that acid coming back up in your esophagus. So relief can include avoiding problematic foods or drinks, stopping smoking or losing weight. Some over-the-counter antacids or acid-blocking medications can be used. More severe cases of GERD can cause an asthma attack, severe chest pain mimicking a heart attack, resulting in bleeding, chronic irritation of esophagus. Last resort surgery is called a fundoplication, and this is to strengthen the sphincter. And that's a last resort surgery. We always want to do what's most invasive first. Untreated GERD can cause a condition called Barrett esophagus. So now I'm going to move to the small intestines. So this is about 20 feet long, smaller in diameter than the large intestines, but it's definitely longer. In order of the small intestines, you have your duodenum, jejunum, and ileum, coiled into many loops to save space. Most of the chemical digestion takes place in the first subdivision, the duodenum. Acid chyme enters the bulb of the duodenum from the stomach, and this is the site of frequent ulcers. Duodenal ulcers is in the duodenum. Bulb of duodenum is the site of most ulcers. Middle third of the duodenum contains opening the ducts that empty pancreatic digestive juice and bile from the liver into the small intestines. These two bumps are called the minor and major duodenal papilla. She didn't really bring that up, but it might be, I would know it probably. Sometimes gallstones block ducts that drain through the major DP, and this causes symptoms such as severe pain, jaundice, and digestive problems. So the functions, this is going to mostly deal in digestion and absorption. You break everything down, break it down in the stomach, and you're starting to turn some stuff around. Chyme is being passed into the small intestine. The small intestine is going to pull everything that it wants out first. And the reason that it's able to do this is because it has different folds, different pieces, and this was in my notes. I'm trying to find the sheet again. The plicae, microvilli, and villi. These are only in the small intestine. These are not in the large intestine because the small intestine is what deals in absorption. So it needs all of those to be able to pull these things out. So it's lined with a mucous membrane and contains thousands of microscopic glands. Intestinal glands secrete intestinal juices that is a rich variety of enzymes as well as water and ions. The pancreas secretes bicarbonate into the lumen, which is the opening of the straw, of the duodenum to neutralize the stomach acid, and also adds enzymes to digest lipids, proteins, and carbohydrates that are absorbed in the intestine. It contains many folds called plicae that are covered in tiny fingers called villi, and those are covered in microvilli. Each one lies in a rich network of blood capillaries that absorb products of carbs and protein digestion, or sugars and amino acids, and lacteals that absorb liquids. Villi allow for faster absorption of nutrients from the intestines to blood and lymph, and they also increase surface area. So if you have all this bunched up and then you were to pull it out, it's kind of like a crinkled piece of paper. When you pull it out, it's going to be a lot bigger than it was in that ball because it had a lot more surface area than you could see. So we had a clinical application on page 372. 1 in 10 people in the U.S. suffer from ulcers, and these are crater-like lesions that destroy the areas of the stomach or intestinal lining and cause gnawing or burning pain, and may result in hemorrhage, perforation, scarring, or other conditions. Sorry, I'm looking over there. Long-term use of aspirin and ibuprofen or NSAIDs can cause ulcers. Most gastric and duodenal ulcers result from the infection with the Helicobacter pylori, or H. pylori bacterium. This causes most ulcers. It's a bacteria. Treatment is the standard antibiotic-based treatment is used most frequently to heal preventing or reoccurring ulcers, and this is called triple therapy. That was like in the quick checks, I believe. So she might ask that. Successful in 80 to 95% of cases, and requires that 3 meds be taken concurrently for 2 weeks. Triple therapy combines with Pepto-Bismol and 2 antibiotics. These are the same ones to treat GERD. I'm going to take a break real quick. I'm just going to be here for like 2 or 3 minutes. If anybody has any questions or anything they want to add, you can comment. All right, I'm going to keep going. All right, so we just finished small intestine and the clinical application on 372, and we're going to go on to liver and gallbladder. I'm kind of trying to bump through this because I think the questions are like the most important part. If you can answer those questions, then you know this, but you can always come back and watch the video too. All right, so the liver and gallbladder. Liver secretes bile. Bile gives feces its color. Liver is a very large and fills the entire right upper section of the abdominal cavity and extends partway to the left side. It secretes bile into ducts, and it's classified as an exocrine gland, and it's the largest gland in the body. I have a feeling she's going to put that on there. Liver also serves as an excretory role and removes yellowish bile pigments formed in the breakdown of hemoglobin from old red blood cells and puts them into bile for elimination from the body. So think of it as bile is not supposed to be there. Not necessarily. Bile is not a good thing. So if you have a backup of bile, if you have too much of it, it's not being sent away as it should, then it's going to cause issues. And this we'll get over to in just a minute. Hepatic ducts drain bile from the liver, and the common bile duct drains bile into the small intestine. I would know the difference between those two because I have a feeling she's going to ask that. It was in a lot of the quick checks and other questions. So, liver continuously secretes bile. If there's no chyme in the duodenum, the sphincter will close and the bile backs up the common bile duct into the cystic duct that leads to the gallbladder. Folded lining in the gallbladder allows it to expand and acts as an overflow reservoir for bile. Gallbladder also secretes stored bile by reabsorbing water from bile back into the blood. So basically, if there's nothing to be messed with in the small intestine, the liver is going to keep sending out that bile, but there's not going to be anything for the bile to act on. So the gallbladder is going to kind of hold it for a little bit. It's just going to store it. And it also is going to secrete it later by reabsorbing water from bile back into the blood. So functions would be, which is really confusing because a lot of times under structure, it's telling me what it does and not what it looks like. And then I get two of them mixed up. But chemically, bile contains significant quantities of cholesterol and bile salts. These act as detergents to emulsify lipids, and emulsify is to break something down. Lipids often form large globules, so they must be emulsified to increase surface area. Bile that's eliminated from the body in feces serves as a mechanism for excreting cholesterol from the body. I'm going to read that again. Bile that is eliminated from the body in feces serves as a mechanism for excreting cholesterol from the body. So remember, she told us that cholesterol can be good, and then we have bad cholesterol as well. So bile is carrying that bad part out. So if it's not being eliminated in feces, you're going to be yellow. And yellow is jaundice, and jaundice is because you have a backup of bile, and that's what gives it its coloring. Emulsification of lipids and elimination of cholesterol from the body are primary functions of bile. Emulsification of lipids, breaking down lipids, and elimination of cholesterol through feces from the body are primary functions of bile. So bile is just a carrier. It needs to break down lipids, and it needs to pull cholesterol out of your body. When chyme-containing lipid or fat enters the duodenum, it triggers contractions in the gallbladder and forces the bile into the small intestine. Lipids in chyme trigger secretions of the hormone CCK. I'm not even going to try to say that word. I'm just going to say CCK. From the intestinal mucosa of the duodenum. So lipids in this wad of watery food and other things is going to trigger secretions of this hormone from the intestinal mucosa. It's going to travel through the bloodstream and promote contraction of the gallbladder, and bile then flows in the duodenum. So they're just triggering each other. If a gallstone is blocked, the common bile duct won't be able to drain into the duodenum. Bile gives feces its characteristic color. If liver secretions are slowed down as a result of backup, bile pigments aren't removed from the blood, and this is how jaundice works. That's why you get that yellow color. Obstruction of the common hepatic duct can also lead to jaundice. And then bile pigments are not removed from the blood by the gallbladder, so no jaundice occurs, only if the cystic duct is blocked. So then we had a clinical application for gallstones. This is basically clumped cholesterol. We want to get rid of cholesterol. If it's not being sent out, what is the gallbladder for? The gallbladder is there to hold what the bile can't send out. Too much cholesterol is going to cause gallstones in your gallbladder. They're clumps of material, mostly cholesterol, that form in the gallbladder, and they're common in 1 to 10 Americans. 1 of 10 Americans. Gallstones form when cholesterol concentration in bile becomes excessive, causing crystallization or precipitation to occur. And the way that I kind of think of it is, have you ever seen somebody that doesn't brush their teeth very well, or if you've watched, I like to watch them on YouTube, it's probably weird, but people getting their teeth clean, especially like in the back of your teeth on the bottom, that's where a lot of your sugar and saliva and a bunch of other nasty stuff and bacteria sit, and it like calcifies. It gets really, really hard, and this is the plaque buildup on your teeth, and it's really like tough. That's what I think of a gallstone as, but inside of your gallbladder, and that rough rock filling kind of thing has to pass somehow, and those aren't fun. So the treatment or dissolvement can be treated over time or prevented by developing in at-risk individuals by oral administration of ursodeoxycholic acid. Surgery to remove gallbladder is called cholecystectomy. Hope she doesn't have us spell those. Pancreas is both endocrine and exocrine. It's an endocrine because it secretes hormones into the blood. Endocrine is into the blood. Exocrine because it secretes pancreatic juices into ducts. So pancreatic juice is the most important digestive juice in the body. Pancreatic juice is the most important digestive juice in the body. It lies behind the stomach in the C-shaped area of the duodenum, and it contains enzymes that digest all three major kinds of energy-yielding nutrients, which are carbohydrates, proteins, lipids. Also contains sodium bicarbonate or alkaline substance that neutralizes hydrochloric acid in the acidic chyme that enters the intestines from the stomach. So it's very, very acidic. All that food that's been in your stomach broken down into chyme. So this is going to kind of neutralize that before it moves on to the rest of your body, so it's not burning it up. Pancreatic juice enters the duodenum of the small intestines at the same place bile enters. And I would look at that on page 1612. I'm sorry, page 372, figure 1612. Common bile duct and pancreatic duct open to the duodenum at the major duodenal papilla. Pancreatic islets or islets of Langerhans contain the endocrine cells that produce insulin and glucagon. So insulin is what's going to lower our blood glucose level. Glucagon is what's going to raise our blood glucose level. And that's going to come up again later. It's going to talk about what can lower and what can raise. And insulin is the only one that can lower, but there's more than one that can raise it. Now we're going to move on to the large intestine. This is, I don't want to say where it gets kind of boring, but this isn't as interesting as the small intestine because it doesn't do as much as the small intestine does. So it's about 5 feet long. It's larger than the small intestine in diameter. It forms the lower portion of the digestive tract. Chyme containing undigested and unabsorbed material enters the large intestine after passing through a sphincter called the ileocecal valve. And this is on page 375. So we're going to go from the small intestines to the bottom half of the small intestine is the ileum to the ileocecal valve, and now we're in the cecum, and then you have your different types of colon. So chyme has the consistency of soup and changes into a more solid consistency of fecal matter as water and salts are reabsorbed through the small intestine. So basically, we eat something as a solid. It's going to be broken down into a liquid, and then it's going to be formed back into a solid because it's going to pull everything out. It's kind of like turds are just dehydrated food, basically. That's pretty gross. So anyways, ileocecal valve opens into a pouch-like area called the cecum, and this is on page 375 towards the bottom. Material in the cecum flow upward into the region of the large intestines called the colon. The colon does not include the entire large intestine, but sometimes it's used interchangeably. So when we say our colon, they're talking about a large intestine, but it's not technically the colon. It's divided into 3 segments. You have the ascending, the transverse, and descending. So ascending, you're going up. Transverse is kind of like what we learned about in the first or second chapter of this book, where like the transverse plane, and then descending colon. So I put you get up into your transverse, and then you sit down. I know transverse like a traverse car. Okay. Material that escaped digestion into the small intestine is acted on by beneficial bacteria. Hold on just a second. There's a beneficial bacteria that communities call the intestinal microbiome or flora. This is in the large intestine. We don't have that in the small intestine. Additional nutrients may be released from cellulose and other fibers absorbed. Bacteria are responsible for the synthesis of vitamin K for clotting and production of some of the B complex vitamins. They are formed, vitamins are absorbed through the large intestines and enter the blood. So we are doing quite a bit in the small intestine, but this is where we start pulling out that last bit, that last stretch. This is what we need before we send everything out through the chute. Intestinal microbiome have immune functions that protect us from many essential diseases. Some bacteria produce gases, flatulence, or flatus. No villi are present. There's less surface area, so there's less absorption. It's basically just a passing tube, and it's only going to pull out a few things. Normal passage in the large intestine takes about 3 to 5 days. In the rate of if the passage quickens, it's going to be diarrhea because diarrhea comes on pretty fast, doesn't it? The rate slows, it's going to be constipation. If you haven't been getting up and moving for a lot, you've been eating a lot of junk food and you're not passing that stuff around on, it's constipation. 2, sphincter muscles stay contracted to keep the anus closed except during defecation. This is the inner anal sphincter and outer anal sphincter, and that should not be hard to memorize. Appendix or variform appendix kind of looks like a little weird worm at the bottom of the cecum, and it contains a blind tube-like interior lumen that communicates with the lumen of the large intestines, and it's 1 inch below the opening of the ileocecal valve into the cecum. So they're running pretty close together. Basically, the appendix serves as an incubator or breeding ground for non-pathogenic intestinal bacteria found in the colon. That would be the main sentence that I would know about this. Appendix, a little dangly thing down there below the cecum, serves as an incubator or breeding ground for non-pathogenic intestinal bacteria found in the colon. When normal microbiome of the gut is disrupted by infection or antibodies, beneficial bacteria hidden away in the appendix can migrate into the colon and restore normal ecological balance. Opening between the lumen of the appendix and the cecum is large in children and young adults. Undigested chunks of fecal matter trapped in the appendix may irritate it and inflame its mucus lining. So inflammation of the appendix is appendicitis. Anytime you see itis at the back of something, it is inflammation of. So common and very serious medical problem, and this has to be taken care of very quickly. Location of the appendix is called McBurney point. See. Then we bump down to colostomy. This is over on page 376 in this clinical application box. Surgical procedure where an artificial anus is created on the abdominal wall by cutting the colon and bringing the end or cut ends out to the surface of the body to form a stoma, which we know we did this in lab. So we're going to move to the peritoneum. This is my least favorite part so far because it gets really confusing. Large, moist, slippery sheet of serous membrane lines the abdominal cavity and covers the organs located on it, including most of the digestive organs. Like I said, the best way to know this or to learn this is to YouTube a video. I think I sent one in a group of a couple of us, and I can send it to the larger group as well. The parietal layer covers the abdominal cavity, and the visceral layer covers the organs inside of the abdominal cavity. So the way that I kind of tried to remember this, parietal layer is going to cover the abdominal wall, the outside. The visceral layer is going to be very close to the organs. That's just how I've always remembered it. If I see visceral anywhere, I know it's going to be closest to whatever's inside of there. So visceral is going to be closest to your organs. Peritoneal space is the space between the parietal and visceral layers. Peritoneal space contains just enough fluid to keep both layers moist and avoid friction during everything that we do every day. Organs outside of the parietal peritoneum are retroperitoneal. Retro meaning like out of, behind. Let's see. Mesentery and greater omentum are the extensions of this peritoneum. Here is the extension between the parietal and visceral layers of the peritoneum and are shaped like a giant pleated fan. Greater omentum is a pouch-like extension of the visceral layer from the lower edge of the stomach, part of the duodenum, and transverse colon. Digestion is a complex process that occurs in the alimentary canal and consists of physical and chemical changes that prepare nutrients for absorption. So I would probably go over this a million times because I feel like she's going to ask us specifically about this, but mechanical breaks ingested food into tiny particles, mixes them with digestive juices in our stomach, moves them along the alimentary canal, and eliminates the digestive waste from the body. So we're having mastication, chewing, deglutition, swallowing. Peristalsis is going to be like the moving down. Segmentation is like the squashing of it. And then defecation. So that is mechanical digestion. Mechanical digestion is going to have the most to do with movement, mechanical and movement. That's the only way that I can really memorize that. You're breaking it down with your teeth. You're moving your mouth. Your digestive juices are going to move around down the alimentary canal. You have mastication, chewing, deglutition, swallowing. That's a movement. Peristalsis, that's a movement. Segmentation, that's a movement. And then defecation, that's a movement. A bowel movement. So mechanical movement. Chemical digestion breaks down large non-absorbable nutrient molecules into smaller absorbable nutrient molecules that are passed easily through the intestinal mucosa into blood and lymph. Numerous chemical reactions catalyzed by enzymes in saliva, gastric juices, pancreatic juice, and intestinal juices. Juice, chemical. Let me see if I can find a way to do this. Mixing Kool-Aid kind of makes me think of chemical digestion. It's changing. You're going to come out with something completely different than what you started with. So chemical digestion is going to be using more juices and enzymes. So we have like amylase in our saliva, pancreatic juices, I believe even some hormones. But these are all going to deal with the mucosa, go into blood and lymph. And that's chemical digestion. It's going to be the opposite of mechanical in a way. Then we have enzymes and chemical digestion. Enzymes are protein molecules that act as catalysts, and they speed up the process without changing themselves. So enzymes are breaking things down, and catalysts are fast. So they're breaking things down quickly. And we are now on page 378. During chemical digestion, certain enzymes very selectively speed up and break down specific nutrient molecules and not others. So hydrolysis enzymes speed up reactions and add water and chemically break down or split larger molecules into simpler molecules. Hydrolysis is the reverse of dehydration synthesis. If you remember that from, I believe, chapter 2, dehydration synthesis was going to build something, or it was going to have something pull pieces out and build from the pieces that it pulled. Hydrolysis is going to be the reverse of that. All digestive enzymes can be classified as hydrolysis because they catalyze hydrolysis reactions. Carbohydrate digestion. Very little digestion of carbs happen before they reach the small intestines because we chew our food so fast that salivary amylase does not have time to work as effectively. So if we took the time to chew like we were supposed to, our food would probably be digesting better. We would probably look better. Gastric juices contain no carb digesting enzymes. So what we're not covering in the mouth is having a hard time being covered later. Pancreatic enzyme starts the process by breaking down polysaccharides such as starches into disaccharides. Remember, poly is many, di is like 2, and then mono would be 1. Intestinal enzymes, maltase takes maltose or malt sugar, digests maltose or malt sugar. So sucrase digests sucrose or common table sugar. Lactase digests lactose or milk sugar. A before O. Lactose intolerance, when someone has a low amount of lactase and have difficulty digesting lactose, side effects include gas, bloating, and diarrhea. Protein digestion. Protein digestion starts in the stomach. Hydrochloric acid in the gastric juice helps unfold the large complex protein shape so digestive enzymes can reach the peptide bond that holds amino acids together. Pepsinogen is a protein in gastric juice that's converted into active pepsin enzymes by the hydrochloric acid. Pepsin begins breaking down peptide bonds to form shorter and shorter chains of amino acids. Trypsin in pancreatic juice and peptidases in intestinal juices finish up protein digestion. So the end product of protein digestion is amino acids. I'm going to go ahead and highlight that myself because that was in a lot of the quick checks, a lot of the questions, and I really feel like that's going to be something she's going to ask us about is what is the end result of carbohydrate digestion, protein digestion, and lipid digestion. And that is in a teeny tiny little paragraph on page 378 under end products of digestion. I didn't put that in the study guide because I thought I covered it in these big parts, but then I realized that they didn't later and it was too late. So if you have a pencil or a pen, I would go and write this down. Let's see. Okay, when carbohydrate digestion has been completed, starches or polysaccharides and double sugars or disaccharides have been changed mainly to glucose, a simpler sugar, or monosaccharide. End product of protein digestion are amino acids. Fatty acid and glycerol are the end products of lipid digestion. Oh, maybe I did write those on there. Maybe it was just the carbohydrate one I didn't. All right, very little fat and oil digestion occur before they reach the small intestines. Most lipids are undigested until after they're emulsified, which is broken down into tiny droplets by bile into the duodenum. Lipase splits lipids into other components. Triglycerides and large lipid molecules are broken down into fatty acids and glycerol. This ends fatty digestion. Absorption over on page 379. Right, after food material is digested, resulting nutrients are absorbed and moved through the small intestine into the blood and lymph. So this is where we are talking about what's needed. We're at the last home stretch. Everything's being pulled out. After food material is digested, that part has been handled. Resulting nutrients are absorbed and moved through the small intestine into the blood and lymph. These are two things that circulate around our entire body and carry things. So we want those things that are being pulled for good to be moved around our entire body. Absorption is the process by which molecules of amino acids, glucose, fatty acids, and glycerol go from the lumen to the circulating fluids of the body. So we're going from the middle of the straw out into the body and to the lymph. Nutrients are meant to nourish the millions of cells in the body. Let's see. Surface area reabsorption. This was like the last little paragraph in there. And this was talking about structural adaptations of the digestive tube, including folds in the lining mucosa, villi, and microvilli, increase the surface and speed absorption and transfer of materials from the intestinal lumen to the body fluids. So it's wanting to pull it out quickly. Fractal geometry, she didn't really go over that, but I mean, I thought I'd put it in there. Study of fractal surfaces where the lining of this small intestine seems infinite because there's so much surface area. These have bumps on bumps on bumps. So basically, it's just fractal geometry is the study of all these bumps. Who knew there was such a thing? So then at the back of the study guide, I had another way of drawing that chart, I guess. Talking about how mineral ions, water, polysaccharides, disaccharides, monosaccharides, proteins, amino acids, fats, fat droplets, fatty acids, and glycerol are all broken down, what mechanism is used to break them down, and where they are sent. I would probably at least look over that. And then I had another for chemical digestion on page 380. You're going to need to know what the digestive juices and enzymes are, what's being digested, and what the end result is. So she's asking, that's also in that other paragraph that we just hit on. So that's the digestive system, and I'm going to go ahead and read over these test questions on the digestive system practice test. I'm just going to do, we'll see how quickly we get through this one. But basically, I'm just going to go over the one that Callie put up. And if you guys will to participate, just type the answer. I mean, even if somebody's already typed it before you, just go ahead and type it in the comments. They're going to go away later. These usually don't stay up when we post the video, but it helps to type that, helps to write, helps for the repetition. So I'm going to go ahead and start if that's okay with you guys. Number 1 is ingested food undergoes 3 types of processes in the body. All cells perform metabolism, but blank and blank are performed by the digestive system. There's 2 blanks. There's 2 that are performed by the digestive system. Yes. Question 1. This is chapter 16, digestive system practice test, the one that Callie made. It says before you start, turn to page 388. Close. So all cells perform metabolism, but digestion and absorption are performed in the digestive system. So it's digestion and absorption. All right, the blank layer of the wall of the GI tract produces peristalsis. What layer produces peristalsis? Okay. Yes, muscularis. Valerie. All right. Muscularis is the layer of the wall of the GI tract that produces peristalsis. So, all right. So if you're not able to comment in the video because you're not logged in, you can just message me through the group me, or you can just like write them down on a piece of paper. That's okay. All right. So the blank layer of the wall in the GI tract contains blood vessels and nerves. It's submucosa. All right, so you have muscularis is the muscle. Submucosa is going to have blood vessels and nerves. Yes, it's submucosa. All right. Blank is the innermost layer of the wall of the GI tract. Remember, we said that the inside of the GI tract is contained. No, you're not. The inside of the alimentary canal is covered in one continuous thing, and this is the innermost layer of the wall of the GI tract. Somebody said it earlier. Yes, mucosa. It's covered in mucous membrane. Mucosa is the innermost layer. Yes, mucose or whatever. Blank is the outermost layer of the wall of the GI tract. Yes, it's serous. All right, so blank and blank prevent material from entering the nasal cavity above the mouth when food is swallowed. So we said there was two things that keep water from coming up the back of your nose. Uvula and soft palate, yes. All right, the three main parts of the tooth. Yes, crown, neck, and root. All right, names of three pairs of salivary glands. Yes, Tiffany. Three pairs of salivary glands. Yes, parotid is one. It's the largest, and it has the mumps. If you get mumps, that's where they are. All right, what are the other two? Yes, sublingual is one. All right, so we have parotid, sublingual, and submandibular. So lingual, when you think sublingual, that's where you would put a thermometer in someone's mouth. You kind of put it in like it's a sublingual pocket is what they call it. in the back of your mouth under your tongue. And then you have submandibular, and mandible is a bone in your face. And then parotid, I believe there's a sinus cavity named after that, but that's in this area right here. This is where you would have mumps if you have mumps. All right, so the tube connecting the pharynx to the stomach. Pharynx to the stomach. Yes, esophagus. All right, 3 divisions. Yes, esophagus. 3 divisions of the stomach. Fundus is the top. Body and pylorus. Yes. All right, so fundus, body, and pylorus. All right, 3 divisions of the small intestines. All right, we got duodenum, jejunum. Yes, and then one more. Ileum, there we go. All right, tiny finger-like projections covering the plicae of small intestines are called, you have plicae, and then you have another small piece, and then another small piece. Villi. All right, the lymphatic vessel in the villi is called the blank. Lymphatic vessel in the villi is called the, that one's lacteal. All right, common bile duct is formed by the union of the blank duct from the liver and the blank duct from the gallbladder. So what's a word pertaining to liver? Yes, hepatic duct from the liver and the blank duct from the gallbladder. Yes, cystic duct from the gallbladder. All right, part of the large intestine between the ascending and descending colon is the, so you have ascending and descending colon. What's the piece right here? Yes, transverse colon. All right, the part of the large intestine between the descending colon and the rectum is called the, yes, sigmoid colon. All right, the 2 most prominent extensions of the peritoneum are the blank and blank. Prominent extensions of the peritoneum. mesentery, and then what's the other one? Yes, greater omentum. All right. Which process, or the process in which digested nutrients are moved from the digestive system to circulating fluids? So when things are being pulled out to be put back into circulating fluids, the blood and the lymph, what is this called? Yes, absorption. All right. That's all the questions I'm going to do from this. I'm going to go ahead and log off. If you guys, first of all, do y'all have any questions? If not, I'm going to go ahead and log off and then get ready for the other one, chapter 17. And that one's not long at all, thank goodness. And it's mostly a lot of charts, but we'll go over what we can. Anybody have any questions? Yes, Tiffany. No. Okay. All right. Well, I'm going to go ahead and log off.